Good morning, ladies and gentlemen. Once again, a very warm welcome on behalf of Criticon 2025. Now we are starting our sessions on the second day. And for this, the first session is Gorakhpur Oration. And for this, I would like to invite our chairpersons over the dais, Dr. Pradeep Rangappa, sir. So please come over the dais. And Dr. A.K. Thakkar, sir. Sir. So please come over the dais. And I would like to invite Dr. Rajesh Chand Mishra, sir, for giving Gorakhpur Oration Masterly Inactivity in ICU. Sir is Honorary Consultant Intensivist and Internist, Sleep Apnea, Shaiba Comprehensive Care Clinic, Sterling Hospital, Ahmedabad. Sir, please.
Good morning, and it's good to start, though little late, but this is okay for us. This topic, masterly inactivity in ICU, I'm not going to talk something new which you don't know. Probably I'm just going to put the whatever we know in critical care at one place. Last couple of years has been time where we have been bombarded in critical care about most of the trial. They are either neutral or negative, means they could not conclude. But the advantage of those trials were that we at least knew that what we should not be doing. And in critical care, this is also a great opportunity that we know at least if we don't do this, we are not going to do any harm. So masterly inactivity doesn't mean that deliberately we are not doing anything. Rather than we know that something we are not doing is not going to benefit the patient or it may harm the patient. And that's why this relies on the primum non nocere, that is first do no harm. And this principle is very well known in critical care. Whatever we do, that at least we should not be doing something which can harm the patient. The core principle are observation before action, respect for physiology, risk versus benefit analysis, patience with therapy. What does it mean? Many times it happens that patients are very stable, but we are intent, like 100-degree fever came, you gave paracetamol. Patient heart rate went from 100 to 130, we give beta blocker or ivabradine. So these stress response are just response because there is some changes happening in disease process of patient which is adaptive and physiological. If we try to control those physiological process, it may harm the patient. If we know and realize that, if we wait patiently rather than targeting the main problem, it may benefit us. Also, risk versus benefit analysis, that you give something, it has two risks, it may harm, it will have cost. If both these things we analyze and we find something not doing in our favor, we should be restraining ourselves. And definitely patience with therapy is another thing, that when you are not doing something, you need to have more knowledgeable, more understanding about the patient and physiology and disease, and then you can take action. Most of the time in ICU, over investigation and over treatment, like because of the multi-specialists coming to most of the places, they will write something because you have called them. Very hardly you find people, they come and just tell you, okay, just wait and watch. Even you give reference to anybody, it will never happen that somebody comes and tell you that, okay, everything is fine, just wait and watch. No, some medicine they will write, maybe it is for placebo, and that habit has to be changed, but unfortunately, that doesn't happen. And whatever drug use, whatever procedure we do, even we give fluid, even we give Rantac, even we give pantoprazole, if it's not benefiting your patient, it may harm your patient. Nothing we do in ICU, it is absolutely safe. It has some problem. So less aggressive intervention to select situation, in select situation may improve your outcome. That's the intent of this. Now some of the clinical scenario and evidence, fever in sepsis or viral illness. Last couple of years I have seen in ICU, resident call you, sir, patient has 98.8 degree fever and we have given 1 gram paracetamol. Why? Why the hell you need to give paracetamol for 100-degree fever? We all know that fever is an adaptive response, it's good for your body, it improves your immunity. Craig will be talking tomorrow about the different kind of temperature phenotypes on the sepsis, and he will tell how important it is about fever is if your patient in ICU have fever. So this is one thing which I need to stop. At least in all dengue patients, all the patients which we treat, if their hemodynamics is not changing, if there is no tachycardia, no tachypnea, oxygen requirement is not changing, even up to 101-degree fever, we never give any antipyretic until unless patient has neurological problem and their saturation, their sensorium is changing. Otherwise, up to 101 degree, because this is the response of your body. His body is fighting against fever. Temperature is killing your bacteria and virus. Why do you want to stop? Why do you want to control it? So there's one thing which is really concerning for us. We all permissive hypoxemia and hypercapnia in ARDS is good, but still I see still a lot of patients, lot of ICU which is coming particularly in periphery. They typically go with the setting which has been taught in anesthesia textbook, which still persists, that 550 ml tidal volume and 12 rate or 14 rate. This is something which has to be changed. We all know that there's some problem in my slides. Some of the slides are why is missing. I don't know. Anyway, permissive hypoxia is one condition that even your saturation is 92 or 89 below, it doesn't harm. Even your CO2 is 60, as long as your pH remains above 7.20, it doesn't harm your patient. We know that. As long as you can wait, but you need to be very vigilant in monitoring hemodynamics, oxygenation, sensorium, other parameters. If other parameters are fine, you have all the time in this world to wait the patient till patient improve, rather than giving high tidal volume, giving high rate, and causing more injury to lung, causing more worsening to the patient. So permissive hypoxemia and hypercapnia is another concept which we should. We are very impulsive in correcting sodium. The moment sodium comes 121, 124, you get a call, sir, 121, shall we start 3% NaCl? This is something which is very standard. I do not have really time to explain the pathophysiology of this. This diagram is very much available, and that's where our concept change about correcting sodium, either it is hyponatremia or hypernatremia. But what I need to tell you that if it is sodium, if hyponatremia has developed rapidly with symptom, you need to correct it rapidly. But if hyponatremia or hypernatremia has developed slowly and it's not affecting your sensorium, you don't need to make hurry, rather than you need to take at least 48 hours time to correct sodium. If you correct it fast, that will paradoxically cause more harm, more neurological damage, and your patient may have permanent damage which will stay for longer time in your ICU. So you need to be very, very careful in correcting particularly sodium, and the rule is correct it the way it has developed. If it has developed fast, if it is causing convulsion, correct it fast. If it is not causing convulsion, not changing a sensorium level, wait for sodium to correct. Most of the time, body physiology and osmoreceptor center will take care of the things, and patient will get better. And most of the time this happens. Most of the things, giving your saline and doesn't cause that change, rather than waiting patiently. Metabolic acidosis. Most part of the world, most of the part where we see in periphery, the moment I see pH, if it is acidosis, soda bicarb is given. If CO2 is high, everything is COPD, and CO2 was out, you increase the rate. This thing has to change. That's why very precisely in this conference we have kept a session of 3 hours only on ABG. The reason being, you need to really understand that ABG is one of the parameters which tells you about the state of the patient. ABG is one of the signs where you, based on those, you need to find out the cause of the problem. ABG is not for treating patient. ABG tells about diagnosis, it tells about the prognosis, it tells about how your patient is doing, the way other signs, heart rate, blood pressure, something does. It is more precise. So correcting all metabolic acidosis with soda bicarb is something which can harm your patient. If you really want to give bicarb, you need to analyze and prove it that it's non-anion gap metabolic acidosis, or if it is high anion gap metabolic acidosis, and if you are correcting acidosis where potassium is normal, probably you are causing more harm. Many patients will develop alkalosis because of that. They may throw convulsion, they may throw anarrhythmia, they may worsen the patient. So a patient who is stable, where acidosis is protective your cell, if you are giving soda bicarb to this patient, this may harm your patient. So you need to be very, very careful when you are correcting the sodium. Same thing happened with CO2. If patient has got COPD, pH is okay, just you are washing out CO2, immediately your patient will develop metabolic alkalosis. That is more harmful. If you go with one thought here, that if you have to compare between acidosis and alkalosis, select acidosis, which is more protective to your cell, which is more physiological, which is better. Alkalosis is more harmful to your patient, more harmful at cellular level. If you can have this thought and concept clear, this may help you in our practice. Atrial fibrillation and cardron go hands in hand. Without thinking anything, the moment somebody throws AF in ICU, without recognizing anything, either most of the physicians or cardiologists, they only know the cardron. And this is one of the worst things you can do in ICU patient when you give cardron to your atrial fibrillation. Because cardron not only causes myocardial suppression, but it causes lung injury. Most of our patients has lung problem, and that's where, and then all of these patients are at risk of having liver dysfunction. So whenever you have atrial fibrillation in ICU, first thing you see that your patient is stable or unstable. If your patient is stable, get a ECG done, analyze this QTC interval. If patient has got prolonged QTC interval, cardron is contraindicated in this patient. If you have normal QTC interval and AF is varying with normal AF, okay, you can give one dose of cardron. But if patient is stable, hemodynamically stable, I will wait to correct the cause. And most of the time, cause of atrial fibrillation in ICU is not cardiac. It's a non-cardiac region. It is hypoxia, it is your vasopressor, it is the inotrope, it is something which is electrolyte balance. So if you can correct those factors in a stable patient, most of the time this AF reverts of its own. So if patient is not hemodynamically unstable with AF, if heart rate is holding, if other parameters are holding, you should do a ECG, analyze QTC interval, and then take your action. That will be more productive, more better for the patient, rather than giving cardron as a blanket therapy. It's time for us to become little precise and more treat our patient better in a cause-related or a reason-related thing, rather than giving everybody a blanket therapy for everything. Sedation, delirium, and ventilator synchrony or asynchrony. This is another thing which is concerning for us. Most of the time, day before yesterday, I got a call. Call was, sir, patient is breathing too much, generating less tidal volume. Can we sedate and paralyze the patient? I'm like, why you want to sedate? The patient is distressed, it should not be done. Give me a video call. I saw the patient. I saw the cuff leaking. He was having less expiry tidal volume, just simple parameter than expiry tidal volume. Just needed to inflate the cuff tube. It happens so many times, so many reasons for ventilator asynchrony or ventilator distress. It can be cuff leaf, it can be you are not setting the proper trigger, you are not giving appropriate tidal volume, or patient demand is more, patient is worsening. So if you don't address the cause and sedate your patient, and then when you sedate and paralyze, then you call that patient has crashed, now BP is low, or patient is becoming more hypoxic. Patient who is surviving because spontaneously breathing with expanded basal lung, patient who is ventilating very well when the triggering is spontaneously, you just paralyze and your basal lung is totally collapsed. Now you have to increase the PEEP, you have to give more support to this patient, patient is going to become more hypoxic, more hypotensive. So whenever your patient is in distress in ICU, it's absolutely not appropriate to paralyze them just because they are triggering too much, they are in distress. Rather than address the cause, try to find the cause, and then sedate, probably paralyze, if you have fixed up everything. Otherwise, most of the time you are going to worsen your patient. So this practice needs to change in most of the places, which is not happening. Neuromuscular blockage, this is another very commonly misused drug for anything. Okay, nothing, you don't understand anything, paralyze the patient. This is what it happens. Patient is distressed, you paralyze the patient. Patient is breathing fast, you paralyze the patient. Every time you paralyze the patient in ICU, the chances of recovery goes down because of the paralytic drug. Patient will stay in ICU for longer time each time you paralyze the patient. Each time you paralyze, the chances of pharyngeal weakness, neuromuscular weakness increases. So we have very strict rule. First you address the cause, then you give good analgesic. Once you have taken care of that, calm down a patient. If you are really pushed to the wall, then only we paralyze the patient. Otherwise, 9 out of 10 times, we don't paralyze our patient on ventilator. And that's the best thing you can do. Even on ECMO nowadays, after 24 hours, we hardly paralyze the patient, hardly. It's like we will take all the help of fentanyl, we'll take all the help of other drugs. But when it comes to paralyzing, it's like that somebody kills me, then only I can paralyze the patient, otherwise I don't paralyze the patient. And it is so important, so very important for early recovery of patient, because we have started realizing you early mobilize the patient, you make the patient walk on bed, you do the early physiotherapy. All these things help the patient early recovery, rather than you paralyzing and feeling very happy, now patient is settled. No, your patient is not settled. After 2 days, he is going to develop all the complications, including VAP, sepsis, ARDS, neuromuscular weakness, and then you will struggle, now patient is not coming out of ventilator. So this is another problem which we have. And we know that in ICU, more than 20% of the problem, there are papers which are important, is caused by unnecessary procedure, intervention. Most of the time, waiting is a valid reason. Doing nothing is something valid decision. So we must choose our intervention properly. Now, this is another very commonly misused drug in ICU, fluid therapy. This conference was fluid therapy. All the international expert has their comment. If you have to go from here, in our context, in India, we have one very unique problem of tropical disease. And as we started going deep into understanding about the tropical disease, particularly dengue, scrub typhus, leptospirosis, or any of them which causes septic shock, sepsis, or capillary leak syndrome. The pathophysiology is not a predominant vasodilatation or myocarditis. Pathophysiology is capillary leak because of endothelial dysfunction. All these patients, when you give fluid, I do not know how much it holds in vascular compartment, but it definitely leaks in third space, and that causes worsening. So what should we be doing now? We need to encourage our patient as much as possible they can take enterally or orally. We have to give fluid only and only when a patient is having shock, which is documented by whatever Professor Tabul has told you in last 2-3 days, are going to talk about. That giving fluid should be very, very judicious approach. If at all you have to give that much of fluid which is required. Try to restrict your fluid, not a liberal strategy, not a over fluid, rather than restrictive and that much which you need. Because all these patients, most of the time when they worsen in ICU, maybe they develop ARDS, maybe they develop renal dysfunction, over fluid. I do not understand why it happens that a dengue patient which is admitted simply in ward, just for observation, why the hell you need to give maintenance fluid of 2 liter or 2.5 liter every day when he can take orally? What is the purpose of giving? No fun. Fluid is a medicine. Use it when it's needed. If a patient can take orally, he can take enough. At least you prevent the problem. So, apart from that, even for sepsis, thought of fluid delivery, how fluid has to be given, is changing. That typical of 30 ml per kg of bolus to the patient specific or precise fluid therapy. We are learning a lot about fluid therapy, but we need to still learn a lot, because this is something which should be your hardcore subject, and you should have mastery in giving fluid appropriately rather than giving too much of fluid. Blood transfusion threshold. Our threshold for giving blood transfusion is very low. The moment hemoglobin is 8 and 9, most of the people start getting flutter, give blood, give blood, give blood. I must tell you that many a time, even on ECMO, many a time, even on the post-op cases, we just wait for giving blood transfusion. We ask the people to take less sample, which causes heterogenic loss. We try to control that, not to give too much of blood, too much of the fluid to this patient, just holding. It saves so much of patient. The moment you give extra blood, you carry a risk of infection to the patient. more load to the liver, which can cause liver injury itself. Apart from that, blood transfusion is not something which is like for anybody, it's a foreign body. It definitely causes problem, even 1 unit. So, if your patient is not bleeding, your patient is not in irreversible shock, apart from that, if it is stable enough, just simply giving blood because your hemoglobin is low is not acceptable. So you need to really individualize the blood transfusion therapy according to the cause specific scenario. And the back of the mind, it should be that's a medicine. It has not to be given when it's not needed. And the threshold for stable, most of the patient is 7 gram and below. You don't need to even give blood product like FFP or platelet if patient is not bleeding. So if we can monitor, but those things require time. Those things require dedication. Those things require frequent calling to the ICU, which most of the people do not have whose patient is there in ICU. So it's fine, easy, okay, hemoglobin is low, give blood. BT is long, give FFP and things are done. So that's where problem is, that despite we know these things, we are not restricting because it demands time for the person, it demands dedication, and it demands more observation, close observation to the patient, which is nowadays in a scarcity. Early dialysis in acute kidney injury. I know it's a very good concept, but I know it's failed badly. It's time for us to decide that apart from your patient has got hyperkalemia, fluid overload, encephalopathy, or severe metabolic acidosis, which is a number one indication to start some form of renal replacement therapy. In most of the acute kidney insult, first thing, I'm giving a very bold statement that acute kidney injury is not a disease of nephrologist. It's a disease of intensivist, because most of the time AKI has to be managed by proper management of hemodynamics. And about hemodynamic management, nephrologist knows that much what I know about transplant. Okay, so it should be very clear in your mind that when it's AKI, it is your disease. You should have mastery in managing hemodynamics, and if you can do that, you can prevent lot of AKI in going CKD, lot of AKI going on renal replacement therapy, and you can also prevent the harm which is done by any form of RRT. Maybe it is SLED, maybe it is CRRT. So early dialysis, because whenever AKI comes to you, it's already too late. You need to assess the patient, resuscitate the patient. As long as he is not having hyperkalemia, he is not dying because of acidosis, you have all the time in the world to resuscitate, monitor, see the response, how acidosis is getting better, how urine output is getting better, and then intervene. So early dialysis concept probably is gone. Post cardiac arrest cooling, we were very impulsive in cooling down everybody, but we know that it's not needed. So don't allow your patient to get warm. Keep a temperature of 35 degree, 36 degree, appropriate, that will not cause harm, and wait for 72 hours patiently. Those patients recover because of the neurological injury, they will recover, they will tell you they are not recovering or not, otherwise whosoever has not recovered, at least you will not be causing harm. Cooling down them below 35 degree is harmful, and it reduces, in fact, the harm which is caused by this hypothermia may lessen the chance of revival of your patient. That's why you need to wait patiently. Many times just people come, okay, nothing is done, at least do an X-ray. Why do you want to X-ray? My patient is absolutely stable, doing fine, my vital parameters are fine, no change, nothing, no fever, no hypoxemia. Why I should do daily X-ray in chest? In fact, X-ray has become so less in my practice that until unless I have to really confirm the tube position or really confirm a document, many times my patient get discharged from ICU without single X-ray since ultrasound has come. It wastes your time. Every time you have to mobilize the patient. Most of us are not having luxury to put the plate inside. You have to move, your tube may get dislodged. You disturb the patient. So be very restrictive. Most of the time you can do away with X-ray if you have a good clinical examination sense on bedside, and if you know your tubes and all positions are correct, so you don't need to do X-ray. And ultrasound gives us much more information than X-ray, and it gives you immediately to take action. Daily routine labs, CBC, blood chemistry, all the. If patient is holding, you are observing, you can delay it for 24, 48 hours. If you're not, all the parameters, patient is in recovery mode. So we have now an impulse, okay. We came, okay, CBC, ESRs, CBC, CRP, ABG, X-ray, this has become routine. Don't make things routine. Assess the patient and then decide, does your patient need that much of X-ray? Because each time you take sample, you are at least wasting 5 ml of blood. You are putting the patient at risk of anemia, putting the risk of taking sampling and sample rate error. So why do you want to do that? So if clinically patient is stable, everything is fine, why can't we wait for this report? And if something happens, you do it immediately. Things nowadays happen in 5 minutes. In 2 minutes, all these reports come. Why do you want to do it routinely and every time? So antibiotic duration and stewardship, we discussed a lot, we talk about a lot. We still do not know how much duration is appropriate for antibiotics, 7 days, 10 days, because whatever data are there, they are for infection. You have to be very, very clear, not for sepsis. If you are giving some antibiotic and if your patient is in sepsis, the duration of antibiotics should be decided as per recovery of patient, not by any fixed formula. If your patient is having pneumonia, ARDS, patient recover in 5 days, you can stop antibiotic on 6 days if everything is fine. You don't need to give 10 days. But if your patient is having pneumonia which has developed in ARDS and hospital-acquired sepsis, and patient is getting recurrent one bout, second bout, third bout sepsis, you cannot make a rule that you give for 7 days and stop antibiotic, your patient is going to die. So duration of antibiotic or type of antibiotic depends upon how your patient is doing clinically, not by any rule. And whatever trial is being done, whosoever does this trial, nobody can make this rule, because we know that every patient differs according to his situation in ICU, according to his situation, his clinical condition, and what kind of treatment and what kind of care he is getting. So we need to restrain ourselves for antibiotic duration, but the rule should be individualized to the patient. Aggressive recruitment maneuver, high PEEP, titration. Don't get impatient for that. It doesn't really work, high PEEP. You have a limitation, and nowadays we have better maneuvers, better way to do the rescue therapy for oxygenation. If you do not have a staff, you do not have people who can prone the patient, if you do not have ECMO, trying this most of the time harms the patient. So until unless you are very expert in doing recruitment maneuver or giving PEEP of 14, 16, 18, and you really know how to apply and monitor, don't go above this. Rather than wait, try to prone the patient, stabilize in that way. So these things should be away from that. Stress ulcer prophylaxis is routine. Kuch nahi diya. If I am not giving anything, at least give pantoprazole. Why to give pantoprazole? It's causing neutrophil dysfunction, severe neutrophil dysfunction. All your patient has neutrophil dysfunction. Except your patient is having risk of bleeding or bleeding. Most of the patients who comes for observation, they don't need stress ulcer prophylaxis. And pantoprazole also not be on single dose, in BD dose. One of the most commonly misused drug is stress antacid, for irrespective of category. We need to be careful and think. In fact, in every prescription we need to think, is really that prescription needed for this patient? So that's important. We are very, very impulsive. We have given feed, RTS spirit comes. Many times our staff tell me that, sir, 150 ml spirit came, I have stopped feeding. हमने कहा, if you put down rice to me also, and if I have ate something, 200 ml will come to me, doesn't mean I don't take feed. That should not be a criteria that you don't feed somebody because 150 ml of RTS spirit has come. RTS spirit should be expedited as per the need of the patient. You give feeding, you improve tolerance, give prokinetic drug, and don't do every 2 hourly aspirate. At least do 4 hourly if patient is vomiting or abdominal distension happening. Otherwise, it should not be routine practice that before giving feed you aspirate everything. Because there is a gastric juice also. Every hour 150 ml, that is also secreted. And tolerance for gastric residual volume is not 150 or 200. We can tolerate up to 350 ml of fluid without any problem. So we need to be really patient about this thing. What are the barriers and challenges in doing this? Many times when we practice, most important is how much critical care we understand. You know, Whatever work we do, if we are as smooth as we close our eyes and we can play the violin when we are playing it, if we become that smooth in whatever way we are practicing, whatever branch of medicine, then your confidence and your trust and convincing power increases. So first, before saying something, we need to master this thing. Before we say that we are not doing things, we need to get convinced ourselves by not doing this, patient will be in safe hand, and then we can only do. Most of the time, these happen stress driven, that somebody will ask why you have not done this test. I'm not bothered about what somebody will ask. I know that whatever I'm doing is correct and doing in the benefit of the patient. So what is the practical issues for this, for doing this masterly inactivity? That you need to assess, reassess, assess and reassess. It's a continuous process. So same patient is new challenge every hour. Observe if you are not doing something. Communicate clearly to your staff as well as doctors as well as family that why you are not doing that, which is then document it and reassess. So putting into practice to be masterly inactive, 5 steps. Build this section, change management today. If it's not, don't do that. Each patient unstable or at risk. If it's not, wait for it. What is the lowest risk? What is the other thing I can do which has lowest risk, a better thing? Try to practice that. Can I define or stop? Yes. If it is, if something not needed, you stop there, and if I have explained properly. But remember when not to apply this, because you should not be going from this hall that you are going to do masterly activity for everybody. So when delay can be dangerous. So any patient who has got shock, not giving appropriate fluid, not giving vasopressin, not acceptable, you cannot observe. You need to do everything. You need to overdo here. You need to over-investigate when somebody is in shock because they are dying. If somebody has major bleeding anywhere which is causing life-threatening problem, you need to. If you have airway obstruction, you need to. If you have stroke, status. So in acute life-threatening emergency, doing over is okay. But when these things are not there, better to have masterly inactivity. Thank you. Thank you for all your time.
Thank you, Dr. Rajesh. I think it needs a lot of confidence to speak like that you are not doing something when the patient is in ICU. And I think you're absolutely right that most of the time when the patient is in ICU, we forget what is the basic disease. And as usual, your talk is very useful, very practical, and I think we all must apply this. Thank you very much.
Yeah. Thank you, Rajesh. So very excellent exposition of various dimensions of intensive care practices with evidence. So excellent talk. So I request all the audience to give him a standing ovation and a huge round of applause for an excellent oration. So since it's an oration, we won't have any questions. So we'll leave it to organizers to take it forward. Thank you, Rajesh.
Thank you, sir. As a mark of respect and appreciation now, I would request our chairpersons, Dr. Rangappa sir, Dr. A.K. Thakkar sir, Dr. Mahim Mittal sir, and Dr. Ashutosh Mal sir to please come over the dais and felicitate Dr. Rajesh sir with shawl and memento.